Okay guys, we're going to start off with cystitis. Remember, it's normally an inflammation of the bladder. It's normally what we think of as our UTI. Our causative agents that we normally think of is E. coli, and for women that can be because of our shortened length end of the urethra, or because of its proximity to the vagina and the rectum. For men, it can be that their prostatic secretions lose their antimicrobial properties. And then also you got to think about with men, as they get things like BPH, that's going to obstruct their normal flow of urine, which can cause urinary stasis. With females and males, it can be trauma. Mostly for the females, it can be vaginal childbirth or sexual intercourse. And with the males, it can be strictures, urethral strictures that are caused by STIs or anything else that can obstruct the flow of urine. Other things is catheterization, improper catheterization, or trauma. So we can have that. Other causes, like we talked about, is our long-term corticosteroid use, diabetes, HIV. So those type of clients are more prone to get an infection or an immunocompromised state. Some STIs can cause, the biggest one being trichomonas, and then certain medications and our radiation. And so like we talked about, your anatomy, physiology, and trauma all play a role in getting cystitis. Assessment. So when we think of a bladder infection, we normally think of frequency, urgency, and dysuria. Those are kind of your hallmark signs and symptoms that most people will present to the ER with, or going to their primary healthcare clinic. So they may also have low back pain, nocturia, incontinence, hematuria, maybe some urinary retention, and a feeling that they are not completing their bladder. Other signs and symptoms could be fever, chills, nausea, vomiting, and flank pain. When we think of those clinical manifestations and we start thinking of the low back pain, we're thinking that maybe it has progressed just from cystitis to maybe a kidney infection and things like that. We talked about in class that their laboratory, and it should be 100,000, I apologize for the error on the PowerPoint, 100,000 or greater white blood cell count via your urinalysis. And this is something that can be done via a dipstick or a urinalysis exam. Red blood cells can be positive. Your leukocyte esterase and nitrate are normally both positive. If the nitrate is not positive, that means it is not a E. coli indicated urinary tract infection. Our serum white blood cells may also shift to the left, and we talked about a lot that they may need a urine culture, but only if it's a complicated case. Urine cultures take time. They normally take 24 to 48 hours to grow out the colony that we're looking for. So it's really hard to say everybody needs a urinary culture. Basically, for taking care of a client with cystitis, it is a lot of health promotion and prevention. Some of these things seem kind of like duh, aha things, but for the most part, some of our patients do not know this. Drink 2 to 3 liters of sugarless fluid every day. The sugarless fluid part may get a lot of people. A lot of people just drink sodas. Okay, be sure to get enough sleep, rest, and nutrition daily. That's kind of just general health promotion to help prevent infection. For women, especially, this is mainly for the women, you always want to clean from front to back. Avoid wearing irritating substances or using them, so bubble bath, scented toilet tissue, tight clothing, so you think of maybe the leggings that everybody wears, or the jeggings, tights. No, most people don't wear pantyhose anymore, but those type of things. Women need to empty their bladder before and after intercourse, and then both men and women need to clean before having intercourse. Frequent urination. Okay, we don't want to hold our bladders. Unfortunately, as nurses, we tend to ignore this suggestion. Then, if you do start to feel any of these type of things, let your healthcare provider know so we can prevent other things. Some of our complementary and alternative medicine, some people believe that cranberry juice helps with that, and it has to be pure cranberry juice, not the cranberry juice cocktail or things like that. So we're worried, they're thinking that the vitamin C, the apple cider vinegar, and the cranberry juice help acidify the urethral tract, which makes it harder for the bacteria to grow. So that's why those three things are implicated. Okay. If we're in the hospital and taking care of a client, though, we're really thinking about preventing a catheter-associated UTI, which is the biggest thing that we'll have. You'll find that many places have nurse protocol that says that the nurses can help determine if a patient needs an indwelling catheter. We want to think about, why do they have one? You always want to use it for the least amount of time possible and use the smallest size. We always want to use strict sterile technique. Okay. Do not inject more than 10 milliliters into the balloon, because as you inject more, that can cause damage to the urethral tract. Keep a closed system. Good peritoneal care. Okay. And then also think about switching out your catheters to maybe silver catheters or silver coated catheters if you feel like they're going to be in for more than 3 days. The silver has an antimicrobial property which helps prevent a catheter-associated UTI. Treatment. What we're going to do is we're going to tell our clients to drink plenty of fluids, which is hard for a lot of clients because we start telling them that and they're already having the frequency, urgency, and dysuria, so they may not want to do that. You want to avoid the caffeine, the carbonated beverage, and tomato products, because it's going to cause further further bladder irritation, make it more painful to go with some of our clients. Normally, though, our patients need antibiotics if it is a UTI, and you want to get them on there as soon as possible. Of course, with all antibiotics, we want to make sure that they finish it completely. So some of the common ones that you'll see is our sulfamides, which is your trithiprone, and then your sulfamethoxazole, which is your trade name Bactrim. And they can normally give that for a 3-day high dose, or sometimes they'll do it for longer term depending on what is going on. Our fluoroquinolines, our Cipro, our levofloxacin, those type of drugs. Okay. With these, we want to make sure that our patient is not pregnant. Okay. They cannot take them if they're pregnant because of the risk for birth defects. Penicillins, you think of an amoxicillin, augmentin. Okay. Cephalosporins they'll use, which is Diceref. And then, so we have all of this to kill the bacteria, but some patients need the phenaprazidine, which is your Pyridium, your AZO over the counter, things like that, and that is going to help coat the bladder, and so it's a topical analgesic. Okay, it's not going to treat the infection, it's just making the symptoms more manageable, so they can't just take this one and hope it'll go away. This one will turn their urine orange or red, and it could possibly stain their clothing, so tell them that is a normal effect. The beginning of the chapter talks about physiological things that are going on. Some women, depending on what is going on, they may need to take estrogen cream because of the lining of their urethra has changed because of postmenopausal effects. So depending on how old our female client is, they may also be prescribed estrogen cream to help with that. They may have comfort measures. One of the comfort measures they can do is a warm sitz bath, things like that. Surgical management is only if they're having issues with obstruction or reflux, and that is where they'll do the cystoscopy or fix any obstructions. Biggest thing with this is teach the client health promotion. and what they can do to help minimize the infection. Okay. Urethritis is an inflammation of the urethra. Its signs and symptoms are really similar to a UTI, but it doesn't have it. In men, they're going to have burning or difficulty urinating and discharge from the meatus. Unfortunately for men, the most normal cause of this, or most common cause, is STIs, including gonorrhea and chlamydia and trich. In women, the causes are normally linked to bacterial cystitis. There's some other syndromes, pyruvate dysuria syndrome, frequency dysuria syndrome, and things like that. You normally see this in our postmenopausal women, or it's more common in our postmenopausal women because of the tissue changes related to the low estrogen. Okay. With this, we're going to ask our client if they have a history of STDs or STIs, depending on what you want to call them. We're going to see white blood cells in the urine, but they may not have the bacteria. And then if they do a culture, they may see an STD. So the biggest thing is the biggest cause is STDs for men, and for women is the low estrogen, so they can do the estrogen vaginal cream. And then the men, they have to treat the STDs. Urinary incontinence. So there's a couple of things that go on with this. Okay, different types. So incontinence is just involuntary loss of urine severe enough to cause social or hygienic problems. Most people think it is normal after you have especially a vaginal childbirth, or as we get older, that this is normal. However, it is not. Okay, a lot of people don't even realize that this is not an abnormal. So one of the common things that we may see is stress incontinence, and this is the most common type. So they may have loss of small amounts of urine during coughing, sneezing, jogging, lifting, laughing, anything like that. And this is because the urethra can't tighten to overcome the increased bladder pressure caused by the contraction. It is common after childbirth, but if the pelvic muscles are reinforced by doing their pelvic muscles exercises like your Kegels, it should readjust. If it's not, then we have other issues. Also, low estrogen levels due to the changes that occur in your vagina and urethral in the pelvic floor. The next type of incontinence is called urge, and this is that kind of like that commercial where it says you gotta go, gotta go, gotta go. You have to go regardless if you just went, regardless of the amount of urine in the bladder. Those people who have this, their bladder can't signal or cannot suppress a signal to itself, and then they have that just urge. Sometimes this is called overactive bladder. So some patients may have this. Some patients can have the urge incontinence due to a stroke or some other neurological problems, so they may have that as well. Overflow incontinence is when the muscle fails to contract and the bladder becomes overdistended. Some places may call it reflux incontinence, others is just overflow. And basically the bladder just leaks out a little bit of urine so it doesn't rupture, because a bladder can rupture. Then we have functional incontinence. So you may have went over this one in Gero, and it's incontinence occurring as a result of factors other than the abnormal function of the bladder and urethra. So everything is okay with our bladder and urinary system. The issue is our minds and things like that cannot do it, or cannot make the connection. So you'll see this a lot of our dementia patients. Not all, but some of them will. So chart 69.5 on page 1499 has some other factors that can contribute to urinary incontinence. Some of our central nervous system depressants, think of our opioids, anything that can lower our level of consciousness. They may lower the urge to void. Unfortunately, our diuretics cause frequent voiding, so that can kind of have that urge incontinence. Anticholinergic drugs, or with side effects, so sometimes it's hard because you don't know if it's from the cholinergic or something else. Disease processes, depression, and inadequate resources. Assessment. So how do we know that they are having these issues? One of the first things we can do is talk to the client. Okay, we want to determine the amount of residual urine. So we want to have the client void, and then we will do a bladder scan, or depending on the physician, you want to do a catheterization post-void to see what the residual amount of urine is. Only a advanced healthcare provider like an APRN, a family nurse practitioner, or your MDs and your PAs can do the vaginal inspection and a digital rectal exam. The reason they're going to do this on both your patients, the digital rectal exam, is that the muscle that controls your anus is also really closely related to your bladder contraction, so they're going to check that. And then also in men, they're looking for BPH or enlarged prostate. Women, they're looking to see if there's what's called a cystocele, and that is where the bladder protrudes into the vagina. So we're going to do that. And then also, the advanced healthcare provider can test the vaginal wall strength when they're doing this. We want to do a voiding cystourethrogram, and that's one of the other tests that they can do. And that's just assessing the size, shape, and support of the bladder. And they want to make sure there's no obstruction, and to see what the post-void residual is. Another thing that they can do is have the client cough, and then see if there's any leakage onto the perineal pad. Also, what you want to do is there's going to be some screening questions that you can ask them. Do you ever leak urine or water when you don't want to? Do you ever leak urine or water when you cough, laugh, or exercise on the way to the bathroom? And have you ever had to use pads, tissue, or cloth to catch urine? And those are just some of, getting your history back. We also want to look at age, neurological status, childbirth, and sometimes they may go into further detail about the childbirth, especially with the women. Bowel problems and habits, okay? You want to assess the client's mobility. Maybe they weren't incontinent. Maybe they just couldn't get to the restroom in time because they couldn't find their walker or things like that. So it's maybe not an incontinence problem, but an other problem. So some of our non-surgical interventions is we want to do what's called the pelvic floor exercises. And this is mainly for women. And chart 69.7 teaches a woman how to do this. Basically, they will want to start their stream, and while they are using it, stop it. So they want to start and stop, start and stop, start and stop. And then they can also do this during the day as needed. You want to have them do a detailed diary, okay? So we figure out when this is happening, what is going on, things like that. And the diary can also help see if there's any triggers. Is it a food? Were you jumping? Any things like that. With some people, unfortunately, it is weight related. It can be related to obesity. So we do want them to lose weight as possible. Okay, because of the increased abdominal pressure from the obesity. Some clients, it can be because of alcohol, nicotine, artificial sweeteners, citrus and caffeine. All of these are bladder irritants and can make you feel like you've got to go. So behavior modification for those include maybe we don't need to eat those. And that goes along with our nutrition changes. They also have what's called vaginal cone therapy, in which is a weight therapy. And it talks real heavily about that at the end of page 1501. And basically, they are little weights that will help the woman strengthen her vaginal muscles. The other thing that we want to do, that the book goes over a lot, is bladder training and habit training. And that's on chart 69.9 on page 1504. So bladder training is, you want to tell the patient go every 45 minutes. And then you want to be able to increase their time, their intervals of when they're not going to the restroom. And then habit training is you want to figure out when the client is going. So you're going to watch the client for 22 to 3 days and get a voiding pattern. And then assist the client to the toilet or bedpan, what seems to be the interval for that client. So this is going to be a little bit differently for each client. And you really want to do this, your habit training, is where you're cognitively impaired and the caregivers are assisting. Sometimes you can do the prompted voiding to help and the bladder training to help. The bladder training is mainly for those who are cognitively aware, whereas the habit training is more for those who are not, and it's mainly that their healthcare providers are finding the client's habits. We can also do some surgery as needed. A lot of it is on table 69.4, page 1503, and a lot of it has to do with depending on what is going on with the sphincters or the bladder. Is the bladder like prolapsed? And then they can also do collagen injections to help, and that just provides support around the bladder neck. The medications, there's a couple different ones. So our anticholinergics, antispasmodics, oxybutynin, tolentindrol, or the Detrol LA, some of the ones that you normally see. So those are some of the ones that I would know. And then the estrogen cream. What is our teaching for the estrogen cream? And that's to, avoid smoking, report any calf pain or swelling, because if they're on the estrogen cream, they are now at higher risk for DVT. And then our Detrol, we want to make sure, or anticholinergics, we want to make sure that they do not have glaucoma. They may have to increase their fluid intake, even though they really don't want to, because of the anticholinergic properties. May also have to increase dietary fiber. And we want our clients to monitor their intake and output to make sure they're not getting dehydrated. And if anything is abnormal, to let their healthcare provider know. And then if they're taking the extended release, make sure they don't pressure chew like with any extended release medication. So what that did was it kind of condensed all the way to 1507. The other thing we want to talk about with those clients with incontinence is psychosocial. Their self-esteem may be changed because they're worried about leaking inappropriately. They may not want to laugh or cough or sneeze or do anything like that in public. And then also, are they worried about smell? Can people have that? Can people smell it? Things like that. Next, we're going to move on to urolithiasis, which is presence of the stones in the urinary tract. It can be formed in the kidneys, which is nephrolithiasis, or the ureters, which is uterolithiasis. Most of the stones are either calcium, struvate, or uric acid. So some of those are what can cause a stone. A couple of reasons that people can have stones or the formation of stones occur is because of slow urine flow. So some urinary stasis, the stones are being collected in the urinary system. Damage to the lining, so abrasions, okay, and then decreased amounts of inhibitor substances in the urine. that would help prevent that. So that's kind of like getting dehydrated. You don't want your patients to become dehydrated because of that reason right there. A high urine acidity or alkalinity or some of the drugs can also contribute to stone formation. We want to look at our family history, even though it's not familial, but it can be because of habits. Normally we see our stones more in men, and the recurrence rates just depend. Okay, one thing to note is a high diet in calcium is not believed to cause stones unless they already have a precipitating metabolic defect. And that can be like hyperuricemia, maybe some more of the struvite, or hypercalcemia, either primary or secondary, related to hyperparathyroidism, vitamin D intoxication, or renal issues. So some patients may think they need to cut out their calcium, but that's not always true. And also a low calcium diet doesn't prevent stones. With our stones, we also need to think of cultural awareness. We normally see it more in the southeastern United States, Japan, and Western Europe. You see kidney stones in more younger adults than older adults, and it's more common among Caucasian. So we want to make sure that we're educating the family as well. They're going to have what's called renal colic, and that is severe pain. Okay, and it's normally in the flank area. Unfortunately, this is kind of a good pain because that means that the stone is moving and it becomes very intense. It's also described as unbearable. Some people have nausea, vomiting, diaphoresis. Okay. If a stone gets stuck, though, it normally does not cause pain. And that is when we have an obstruction. You'll see the oliguria and anuria, which leads us to believe about a urinary obstruction, in which that becomes an immediate emergency because now we're worried about kidney function. The client may be pale or ashen. Vital signs are going to be elevated. Okay, you think they're in pain, physiological pain, so their body temperature can be up and their pulse can be up. We're going to do a urinalysis on these clients. They may have hematuria, and it may just be smoky or rusty. Another assessment finding that we can do is our KUB, so you will see your stones on your KUBs or CT scans, and sometimes you can even do a non-contrast CT scan. An IV urography is also really good at seeing if the urinary tract is obstructed, and we want to make sure that we're being careful with our clients because if we are going to give them dye and things like that. So on page 1509, figure 69.2, it has a little arrow showing the kidney stone. And most kidney stones, we think of kidney stones, we're thinking of huge kidney stones, but most of them are the size of a piece of sand or smaller. And when they do pass the kidney stones, or they're at the house or in the hospital, we want to make sure that the patient is using a filter so they can take their stone back to the healthcare provider, or we can send it down to lab to see what the composition of it is. Treatment is pain relief. Okay. NSAIDs, our IV NSAID is Ketorolac or Toradol. So we want to also be careful when we're using NSAIDs because then our increased risk of bleeding. And they can also use opioid analgesics. The higher the stone, though, this is where it gets worrisome, is it has a lower chance of passing the stone. So we're really thinking that they can pass the stone when it is lower. Then we'll do what's called lithotripsy, or the extracorporeal shock wave lithotripsy, the ESWL. The client is moderately sedated, and they're going to lie on the flat table, and they're using the lithotripter. Okay, they're going to do an anesthetic
anesthetic cream over the site because it is fairly painful, and they're going to use, monitor the client's EKG. And then it's just the waves are applied to the area, and then we're going to make sure that that stone is broken up, and we're going to ask the client to strain the urine. During this time, they may add a stent into the ureter or prior so they can make sure that the ureters are open big enough to pass it. You can also do a nephrotomy, is the removal of the stone in the kidney, or it can be the ureter through the skin, and that's done with fluoroscopy and general anesthesia. Okay, and they may use an intracorporeal ultrasonic or laser lithotripsy to help break it up during this section as well. If they need other surgeries or they have tried all of these lesser invasive things and we're worried about long-lasting injuries, we're going to think of an open urolithotomy, which is into the ureter, a pyelolithotomy, so into the kidney pelvis, or a nephrotomy into the kidney. And this is normally done for our larger stones or impacted stones, and they really want to make sure that they've done everything else possible. Normally we're going to give broad-spectrum antibiotics, such as aminoglycosides, which are gentamicin or cephalosporins. And then, if it is a struvite stone, they normally always get antibiotics, and they may need periodic and long-term monitoring to make sure that the infection is cleared. Okay. Nutrition therapy for these clients are really important because we want to make sure that they are getting adequate fluid, 2 to 3 liters a day, unless they have cardiac issues or some other type of issues. And this will also help prevent obstruction of a stone, and also helps prevent formation of a new stone. Drug therapy just really depends on what the reason is. We're going to have, if they have hypercalciuria, which is high levels of calcium in the urine, we're going to give them thiazide diuretics to help lower the calcium level in the urine. And then depending on if they have uric acid stone formation, we're going to give allopurinol. And then we always need to teach them about their self-care on 6911 on page 1512 is for our urinary calculi. What are we going to do? We always want to make sure they finish their antibiotics, resume usual activities, and then you always want to balance, Depending on how it's going, it may be 2 days to 6 weeks after surgery, depending on the intervention, the tolerance, and what the physician determines. And then always at least 3 liters of fluid unless otherwise noted. The next thing we're going to talk about that finishes up urinary problems is urothelial cancer, which is most often the bladder cancer, and then second site is your kidney and your renal pelvis. With this, the tumors are normally confined to the bladder mucosa, but they may spread to the bladder and then to the other surrounding tissue. So normally it's just kind of in the lining, but it can spread. If it is not caught in time, it normally likes to spread to the liver, lung, and bone, which of course decreases our prognosis rate. One of the risk factors is exposure to toxin, and we're talking about some of the chemicals used our hairdressers use, rubber, paint, electrical cable, textile industry, so some of those type of chemicals. The greatest risk, however, is smoking. So we normally just think of smoking as being lung cancer, but however, when you smoke, yes, it goes through your lungs, but it can also go through, the effects of smoking are also seen throughout your bloodstream. like the vasoconstriction and things like that. It can also be people who maybe not work in those type of situations, but who come in contact on a daily basis, especially hobbies like refinishing furniture, car painting, things like that. So we also need to do some health promotion and teach those patients to always make sure they're using proper equipment. Your patient normally, they may have dysuria, but really the only thing, the earliest manifestation comes with blood in the urine, and they may not even seek treatment for that because it could be intermittent, or they're thinking it's an STD. So really, there is no, they're going to have hemoptysis or anything like that. It's very vague. The only significant finding is you may see gross or microscopic hematuria. The biggest thing that we're going to do is a bladder wash specimen through a cystoscopy, maybe even a biopsy, and then a CT scan can show if the tumor is remaining in the bladder or has invaded deeper, and you may even need to do a MRI. What they will do is a radical surgery, intravesical chemotherapy, radiotherapy, or both. The biggest thing that you will see with this one that you normally don't see with other cancers is they will do an intravesical installation of Bacillus Guarimarae, or BCG, which is a live virus. And they do this in adjunct to our chemotherapy. When they do this, they will inject the agent into the bladder, and then the client has to let the agent dwell in their bladder for 2 hours. And then once they do that, then they have that live virus excreted out through the urine, which causes issues for the client and their family. If they only have one toilet, they need to make sure that they flush after each use and add 1 cup of undiluted bleach to the bleach water, and then flush 15 minutes after adding the bleach water, and make sure that they're cleaning everything with the toilet with 10% liquid bleach, and then making sure they're getting rid of the cloth or anything like that. If they are, for some reason, maybe they're having some incontinence and they have any underwear or clothing that has come in contact with the urine after 24 hours of the installation, should be washed separately in bleach. And this is to make sure that the virus does not get transferred to the other family members. You also want to make sure that they are avoiding sexual activity for 24 hours. They may use radiation also as well, and then the multi-agent chemo is good at prolonging the life, but normally if it's already metastasized to the distant sites like the lungs and things like that, they may not, their prognosis is still not good. A couple of surgeries that they can do, just depends on what the stage is and what is going on with the client. So they can do a complete bladder removal, which is a cystectomy, and that also includes removing some of the surrounding tissue. Then you have to think about how are they going to use the restroom afterwards. And on page 1514 it has some really good pictures. So we have urostomies, urostomies, and this is going to divert urine directly to the skin. Okay. The patient has to wear a pouch, similar as they would to an ostomy. Then we have what's called conduits, and you normally hear them called ileoconduits. And this is where the urine is going into a portion of the intestine, and then they will still have to wear a pouch. They can also completely divert that so you don't have to wear a pouch, and they can do what's called a sigmoid ostomy, which is where the tubes are connected directly to the sigmoid colon in the large intestine. So every time they need to go to void urine, they may also void bowel as well. So that one can cause some incontinence. And then you have other ileal reservoirs like Cox pouch, and that can be done through, it's kind of almost like a suprapubic catheter for the client, but it's not in the bladder. Okay, so we're going to do a lot of teaching, okay, same as you would for any of your clients with cancer. You may want to think about electrolyte imbalances. And then depending on what type of urinary diversion they're using, you may want to do some different nutritional things. If they're using the sigmoid ostomies, you may want to tell them to avoid gassy foods in case of flatulence, because the flatulence can cause incontinence. You want to talk to them about self-care, okay? Also social stigmas with this, okay? It says that in men, if they divert into the sigmoid colon, that's going to be different from them, because now they cannot no longer stand to urinate, but they may need to sit. So there's going to be a lot of psychosocial, like with most of the other cancers. And that is the end of urinary problems.